That was nice. Very nice.
Thank you.
Good hype music for a lecture.
Exactly. All right. I guess we'll all start with some introductions while people start inputting where they're from and their program in the chat. So it truly is my pleasure to introduce our speaker today, Dr. Nicholas Christian. He is currently the Chief Resident in Internal Medicine at Dell Medical School at the University of Texas. He will also be pursuing a fellowship training at the Yale program in addiction medicine starting this year. Dr. Christian has led impactful work to address the opioid epidemic, both as a medical student and as a resident in the Distinction Program in Care Transformation at Dell Medical School at the University of Texas at Austin. During his residency, he also became one of the founding members of the B Team, a nationally recognized hospital-based program to increase access to medications for opioid addiction treatment. He is also a missional resident living at Community First Village, a master planned community that provides affordable permanent housing and a supportive community for men and women coming out of chronic homelessness. His talk today is called How to Be an Agent for Change. Dr. Christian, thank you very much for being with us today, and over to you.
Awesome. Thank you so much, Alessandro. And thank you for everyone for putting in where you're coming from. Man, I didn't expect to find another Texan in this group, but that's exciting, Rodrigo. Lots of MPH and MD students. That's awesome. I hope that you'll find something relevant in this. Oh, we even have some Brazilians. All right, it's great. Oh, Toronto. Ah, dang, I got excited. The other U of T. I should have known. But welcome, everyone. I hope that this can be an interactive session. I'm assuming that you are able to unmute yourself if you have a question. Feel free to stop me or fire it in the chat box. I will do my best to keep an eye on that. And I'm hoping that at the end, we'll have some time for a little bit of interaction and a little bit of practice for creating personal narrative. And so with that, I think I'll get rolling, but thank you so much everyone for joining. I know how hard it is to go through these virtual lectures. So let me know if it's getting too boring and I will speed through to the more interactive stuff. And keep an eye out in the slides. My main points, I'm going to take you down a windy path, but the main points are, you're going to see this guy, our change agent. And it's so exciting. I'm like, when Alessandro asked me, gave me a call to ask me to talk at this session, I was so jealous of you guys for having an interactive virtual community of different IHI Open School chapters. That was something that I know I didn't get exposed to outside of attending some conferences that I'll talk about. And so kudos to you guys for being here and for putting on this event. Oh, I forgot I threw a pun in here. Sorry. The plan for today, I don't know if anyone on the call has been to Costa Rica, but this is Cerro Chirripo, and it's the tallest peak in Costa Rica. And myself and my partner, we climbed it 3 years ago. And it was definitely one of the most arduous hikes I have ever been on. And when I think about mountaintop experiences, or experiences where, man, you've overcome a lot and you have stories on how you got there. To me, I just think that sets the framework for channeling your inner change agent, acknowledging what you've been through and sharing that journey with others is a really powerful thing. And so I hope to model some of that with you today, sharing this leadership journey, which is the path that I've been on up until this point in my career. And I want to talk about some tools IHI gave me, which I kind of view as the signposts here. And then I want to talk about how to connect with your community, maybe some tips around that. I don't have a good metaphor here, maybe like your hiking boots or something, where the tread hits the pavement is kind of where we'll focus in on, as well as some examples for addressing disparities in your community. And I guess if we needed to stick with the hiking metaphor, maybe that would be like, if you got a rock in your shoe, maybe, and you're trying to figure out how to most efficiently get outcomes accomplished, which in this case, the outcome is get to the top of the mountain. So I am going to start with, this is where I'm from, Ohio, here in the US. And I am originally from this big corn area here. Not much going on from a small town. I graduated with a public high school class of 60 students. And then I did undergraduate training at Ohio State University, where everyone eats, sleeps, and breathes Ohio State. And then I went to the land of the pilots in Dayton, Ohio, where I did my med school training. And so growing up, I honestly didn't know what I wanted to do with my life up until probably my third or fourth year of undergraduate training. And for the longest time, I thought that I wanted to be a community organizer. I had started this nonprofit music festival, and it started out mainly just to showcase bands that I was playing in at the time in high school. But then it ended up growing into this big nonprofit group where we raised money and we donated it to local charities. And it was a big ordeal, and I loved it. I loved interacting with others. I loved bringing people together that normally wouldn't be at the table together. And it was fun. And obviously my band always got to play. So that was like the side perk as well. So I got into medical school. And that's another long story. If we have time and you're interested, happy to share that path. But during my first year of med school, I heard about this dual degree program where you could get an MD and an MBA, Master's of Business Administration. And so I was accepted into that program. And one of my mentors, who was a fourth year med student at the time, was in the IHI Open School. And he was like, Nick, I'm going to take you under my wing. You got to check out the IHI Open School. It's really cool. And he recommended that I go to the Student Quality Leadership Academy. And this was in 2012. And I don't, for those of you that have been involved in IHI for a while, you might have heard the name Marshall Gans, but he is a renowned figure in social activism, part of the civil rights movement, a part of, you name any movement between then and now. He's a part of Obama's campaign. Like, he's done incredible things. And I heard him talk and was just so inspired, because he's like talking about how to really like motivate people and how to get things organized. And so this was me. I was like, I raised my hand, and I'll never forget this moment. I was so excited to ask this question. Threw my hand up as soon as he opened it to questions. And I asked, so how do you recruit resources towards your cause, Mr. Gans? And I'll never forget his response. And it was, he flipped it back on me. If resources aren't attracted to your cause, you probably have the cause wrong. And this was my response to that. I won't make you watch that again. Sorry. I love Tim and Eric Awesome show. So tip number one, pick the right cause. Like, you got to know your people, and you got to know what you're trying to organize for. And causes change and they morph. And it's really important to just be cognizant that not every cause is worth organizing around. And some people might have a great idea, but that idea might not be worth pulling resources around. So just be mindful of that. As you're trying to motivate others to create change in your communities. And so I was a fourth year med student at Boonshoff School of Medicine. I had completed my gap year of getting my MBA as well. And I was like getting ready to apply to residency programs. And I found myself in the IHI Open School chapter, and I was the chapter president. And I honestly was like the only member in our IHI Open School chapter. I was the president, and I was trying to recruit others. And the focus prior to my tenure as president was, hey, you should take these IHI Open School modules and learn about quality improvement and learn about PDSA cycles. And I really think that focus, the modules are incredible. I recommend them to everyone. But when they're forced upon you, which is what our med school did, people didn't want to participate or have anything to do with the open school, because it wasn't voluntary. They're like told. And I found myself all alone in my open school chapter. And so I scratched my head and thought, man, what would be something that I could potentially do to rally people around a cause? And of course, Marshall Gans was in mind. And I do love that the quote that you shared, Jenna, from Marshall, definitely hits the nail on the head. And so NBC News released this around this exact same time when I'm having these thoughts. Like in Ohio's Montgomery County, where Dayton is the county seat, 512 people have died this year due to accidental opioid overdoses. And not only that, here are this is like has just been released within the last year with some of the geospatial profiles of where people were overdosing. And you can see this hot red spot, the change in relative risk of opioid overdoses. That's exactly where my med school is. It's exactly where I'm from. And for those of you, those MPHers, maybe in Epi, you'll appreciate these charts kind of highlighting the age group, the demographics of the people that were overdosing at the time. Men are in this purple and females in the pink. So mainly 30 to 34-year-old men, which is tragic. And I really wanted to bring attention to this type of chart, which for those of you interested in healthcare disparity work, I think that these sort of breakdowns are the way forward to identify needs. And so as you can see here, this top line is white males. And these are deaths by prescription opioid overdoses. And of course, we have the years going left to right. But look at this red hashed line that's just cutting over all these other lines and increasing at an exponential rate compared to the other curves. And that's Black males. And so that's been really alarming in the field as of lately, that people aren't recognizing, at least here in the US, a lot of reason why the opioid epidemic has had such an impact is because it involved white males. And in this place of privilege, our society has finally paid attention. But it's important to note that that this is also impacting people of color at a rate more than white males. And so I think that it's important for us to put on this health equity lens and to break down our different populations so that we can develop interventions focused on each of those populations. And then something for me, so like I said, the opioid epidemic hit my area really hard, and I've had two close friends overdose and die. One of which I played music with, we were really close. Another that was in my high school class that we played basketball together. And I think I'm just really, early on, I think I acknowledged that, man, these people that are overdosing are friends and family and brothers. And it really opened my eyes to the fact that this is something that's really important. It's affecting my life, and it's something that is affecting thousands of other lives. And so from that space, strategy is turning the assets we have into the power we need to get the change that we want. And these slides with the IHI logo in the corner are pulled directly from Leadership and Organizing for Change course that you can take through IHI. And that I took that course right at this time as well. And it really pushed me to think through how to organize our chapter around this cause. And so to this quote, like, strategy is turning the assets we have into the power we need to get the change that we want. So you got to start with the assets. And I just happened to come across this organization called the Community Overdose Action Team, which was organized by our public health Dayton and Montgomery County seat. And this group was already coming together and had different branches focused on the opioid pandemic. Illegal opioid supply control branch, education and information, a prevention, treatment and recovery, prescription opioids, and a harm reduction branch. This was already organized. And I attended the treatment and recovery branch meeting, and my mind was blown. I was like, man, why aren't there students that are helping advance these projects? A lot of people had great ideas, but they didn't have the energy or the time to see them into action. And so I also saw the assets of, man, we have med students. We have all of these other students that are involved with our IHI Open School chapter, nurses, professional psychology, social work. And then there was a pharmacy school that we had partnered with. And this, looking at these assets, I realized that, man, we need to create a coalition. And so we created this group, the Student Opioid Coalition, with the main goal of taking students from each of these programs and putting them into projects that align with the Community Overdose Action Team, a group that was already going on in the community. And the results that we had here, I'll just quickly walk through these slides. This also is directly from the Leading and Organizing for Change course. Know Why You Care. I kind of walked you through why this was so important to me. Set a measurable aim. For us, it was to create a group and plug students into projects and see these projects take off. We started small. We started with the treatment and recovery arm and the prevention arm. In the prevention arm, we ended up distributing medication disposal kits. And then we also in the prevention realm, we hosted naloxone training, which is the opioid overdose reversal medication. I already mentioned the asset-based approach. And then building relationships came along with that, meeting with people, having one-on-ones with these, with the Community Overdose Action Team, as well as students that were interested in participating in these projects. And we distributed leadership. We were a very flat organization with the goal of empowering others to create their own initiatives. And we developed a learning community, and it was a blast. So the results, we went from essentially an IHI Open School chapter of 1 to having like 55 students engaged in our work through the Student Opioid Coalition. And there were over 7 disciplines involved. 5 project leaders were identified. This is by the time I had left. And so like this was launched maybe 6 months. And in those 6 months, it just came together so quickly. We hosted an Narcan training event. And like I mentioned, the medication disposal kit project. And so one thing that I really wanted to drive home here is just identify your assets. It's super important to think outside the box and to have people with different backgrounds at the table, because people view assets differently, and it's important to have that diversity in our organizations. And so fast forward here to residency. I chose to come to Dell Medical School down in Austin, Texas. Mainly, I was inspired by their mission of revolutionizing how people get and stay healthy. And they're like the first medical school to open at a major institution in the last like 20 years. And so it was like a big deal for them to start this med school and really be able to do things differently in order to achieve this mission. You guys are well aware of how devastating the opioid epidemic has been. This is another chart of overdose deaths. 70,000 in 2017. This is the time that I was starting residency. And this truly is the pandemic of our time. Like gun deaths in 1993 only hit just over 30,000 deaths. And then HIV in the middle of the HIV pandemic in 1995, just over 40,000. And so I just wanted to highlight in another way, like this is a big deal here in the US. And I know I've done a lot of reading on the response to drug overdoses in Vancouver. So I know that it's also hitting you guys very hard as well. And we have evidence on what works. Naloxone works. And then treating patients while they're in the hospital with medications, either methadone or buprenorphine, initiating buprenorphine treatment for hospitalized patients with opioid dependence, it's shown to decrease mortality. Mortality in year after overdose lower with methadone or buprenorphine treatment. Like we have gold standards of treatment, but for some reason we're not seeing that treatment being offered, especially not here in the US, and definitely not in the South. And so I wanted to walk you guys through a tool that I found super effective in my work throughout residency. which is the model for improvement, which I would imagine you guys have heard at this point. So we're going to walk through it. First step, what are we trying to accomplish? So in my project, I wanted to increase access to buprenorphine for patients admitted to the hospital with an opioid use disorder. And how will we know that change is an improvement? Well, one, we'll know by the number of patients that we start on buprenorphine or methadone. In this case, we decided to focus in on buprenorphine just because it's more widely available for patients when they leave the hospital. Number two, we'll know that change is an improvement if there's a high percentage of patients that are continuing treatment after discharge. We don't want to just start patients on this treatment while they're hospitalized. That does them no good if they don't have access to it at discharge. And so we want to be able to prove that patients are continuing this treatment. And then what change can we make that will result in improvement? So we decided that you could screen patients for opioid use disorder and eligibility for buprenorphine. Start buprenorphine while the patient is hospitalized. For those of you that don't know the term buprenorphine, that's also Suboxone. You might have heard that term. And then after patients are hospitalized, we will link them with an outpatient clinic so that they can continue the medication when they're discharged. And so plan, do, study, act. We have what we're trying to accomplish. We'll know what we're measuring. And what change can we make? Well, we got to develop a process to do this. And that process is what we have endearingly termed the B team, or the buprenorphine team. And not to be confused with the A team. I think a lot of you are probably too young to even know the A team, but I would imagine you know Mr. T here, who was a member of the A team. But you got to page the B team full. And so we're a team of interprofessional members. There's a nurse, case manager, pharmacist, chaplain, a peer recovery specialist, myself as a resident, psychiatrist as well on the team. We screen patients, make sure that they're eligible to take buprenorphine, make sure that they're interested. We see them, and if the patient's interested and engaged, we will start the medicine for them. And then we transition them to an outpatient clinic where they can continue the medication at discharge. And so measuring for improvement, what did we see? So within just the first year, the service volume, or excuse me, this is within the second year, this is the number of patients that were referred to the B team, 140, 84 of those 140 referrals that we received were started on Suboxone or buprenorphine. 75 of those were discharged with a prescription for buprenorphine or Suboxone. And then in the outpatient clinic, 59% of patients started on Suboxone, attended their first outpatient appointment. 38% were still involved up to 3 months. 26% stayed engaged between 3 and 6 months. And 22%, or 1 in 5 people, were engaged in treatment over 6 months since discharge, which are phenomenal numbers and very comparable to other programs that are doing similar things. And we did all this. What makes our program semi-unique is none of us are addiction medicine specialists per se. Like, we have this expertise in buprenorphine, but a lot of programs think that you have to start by hiring an addiction specialist. But this was a quality improvement project that inspired us to use the assets that we already have to start this medication. And it has found great results. This is for all you stats nerds out there. And I'm just going to briefly talk through this. This is what you call statistical process control chart, or SPC chart. And as you can see, like, you can track the upper control limit or lower control limit, and you can see when track over time and track common cause variability versus special cause. And I won't go into all those details, but essentially you can tell that there's a lot of numbers above this line. So you know that what we changed worked. And that's when the B team launched. And this is the total number of prescriptions for buprenorphine in our hospital. And just as a control, this is showing that there really isn't all that much variation in the number of patients that were admitted with opioid use disorder that wouldn't skew those our data. If you're interested in learning more about this stuff, you can take a Six Sigma course. I got green belt trained during medical school, and I found it fascinating. A lot of that is out of my brain at this point, but I would imagine it's like riding a bike. And then this is a great IHI Open School module if you would like more a more in-depth description of SPC charts. And it's been way more than the numbers. And what really has made our team work is our providers and the culture in our hospital has changed tremendously, because people feel like they have a tool in their tool belt to treat patients that otherwise were difficult patients. These are patients that feel terrible, that are often nasty with staff because they feel terrible, and also staff treats them differently in a negative way. And now there's an option for us as providers to help them, and previously there wasn't that. It's not only impacted providers in our hospital, but this is a quote from an outpatient case manager who was seeing one of the patients that we discharged. She shared with us, "I wanted to share with you all that during the assessment, he became quite emotional, started crying to the point where he could not talk, not just tearful, and expressed a lot of gratitude for everything you all have provided there for him. He acknowledged that he was so relieved to not have been kicked out after having been caught using in the hospital. He got caught using heroin in the hospital, and we accepted him where he was. But more importantly, it really seemed to be about his feelings and almost disbelief that they actually really care about me. It was kind of heartbreaking, but very awesome that you all have made such an impact." And to me, that's what this is about. It's like making sure that these patients know that, hey, we care about you, because they have been told all their lives that no one cares about you. You're an addict. You're useless. Do something with your life. And in reality, they've probably just been waiting for a hand to be reached out to them. And as an agent of change, like we can be that hand for people. And so my third tip is to use the model for improvement. It works. I have seen it work time and time again. It's really hard to really hold yourself accountable to PDSA cycles. But I tell you what, if you can do it, you are going to make a change in your project. And you're going to inspire others to hold yourself accountable to always work towards changing others. And so during residency, throughout all this, this is the outside of the home in which I am presenting from right now. And so you could see I live in a it doesn't take long for the tour. It's a very tiny space, but filled with lots of love. These are some of my neighbors, and I won't explain much. I apologize. Oh, I'm going to start with this quote, actually, and then I will turn towards my vanity. So I was at the IHI National Forum 3 years ago, and Father Gregory Boyle, which is funny, a priest speaking at an IHI National Forum sounds weird, right? But his message was so powerful. He said, "We are sent to the margins not to make a difference, but so that the folks on the margins will make us different." And I want you to sit on that quote for a little bit, because it's a huge paradigm shift in how we think about serving underserved populations, especially those of us interested in this disparities work. We feel like it's up to us to change others. And that's also something that is just embedded in the culture of medicine. It's called the writing reflex, always wanting to write something. But in reality, so I heard this quote and I thought, oh my gosh, like I have got to get myself into, if I want to serve underserved populations, I've got to be changed myself. And so that's been my mentality with where I live. Instead of describing to you where I live, I'm just going to share this news piece. And I know it's really vain to show a video of myself, but it's the only way for me to fully show you what life is like here where I live. You want to do like a blues? Another blues? Let me hear it. Ooh.
You may be listening to the blues, but it's all smiles under Nick Christian's roof.
I don't know why he give up a big old spot for this big old mansion we got.
It feels like my home isn't just in these walls, you know, like it expands.
He hasn't been in Austin long, but he already feels at home in this tiny abode.
Life is great. It's not hard to make friends out here.
Nestled within the Community First Village.
Right away, the first person I met is one of my best friends here. I call him Pops. And we just started playing music together. And I realized, man, I think that I'm being called to move out here.
About 200 people call this neighborhood home, most of whom were homeless.
That inspired me.
But Christian didn't come from the streets. He's a doctor pursuing his residency at the Dell Medical School.
And through working at the hospital, we see patients come through the emergency department and get admitted to the hospital that come from a homeless background.
To gain that level of understanding, Christian decided to be a missional, a person who supports residents transitioning out of homelessness by simply living amongst them.
We have school teachers, we have nurses, we have physicians.
To Mobile Loaves and Fish's Alan Graham, ending homelessness takes more than housing, but also a social support system that many residents didn't have before.
We had the walls that we could lean upon. The men and women that we lift up off the streets don't have that. And the missional community brings that level of stability.
Oh, yeah.
And Christian wants to take that further. As a physician, he also wants to make sure the homeless feel supported when seeking medical care.
To me, I think one of the ills of healthcare right now is sometimes we depersonalize care. You need to proximate to the poor if you really want to serve the poor and underserved.
An idea that is music to his ears.
And it aligns perfectly with my personal mission, which is we need to love and show mercy to those that are less fortunate than ourselves.
Victoria Moran and Spectrum News.
Yeah, I'm ashamed. I'm sorry, guys, that I had to show that video, but I think it just paints really well. It's better to just show than to tell you what this village is about. So I'm gonna, if you have questions about Community First Village, which by the way, you are welcome to Google it. I'm gonna throw the name in the chat box. So I just wanted to provide a couple frameworks for how you can embed yourself in a community, and also like how to understand more about a community. And so one way is to listen for unmet needs. And there's this organization called the Value Institute for Health and Care here at University of Texas, the other UT. And they host their experience groups, which are open-ended focus groups to understand what success means to a group of individuals and how that success is enabled or impeded outside of the clinic or embrace of care. So it's like trying to understand what's going on outside of the clinic setting, and what are the concerns that a patient has outside of what they're telling their doctor or their nurse. And so we decided to host these groups at Community First Village. And I mean, what inspired some of this work is I had heard from many of my neighbors and witnessed firsthand that a lot of people still aren't getting much health care. And we wanted to understand why. And these were the 4 themes that we found. And I'll just share some quotes with you guys from some of my neighbors. So the first theme, which by the way, there were 25, for those of you interested in methodology, our N was 25. And we did, I believe, 4 different focus group sessions with open-ended questioning to help just create conversation amongst the participants. And so here are some quotes that are pulled directly from the transcript. So a lack of trust. The first person I talk to when I go to the hospital, even if my hand is cut off and I'm bleeding to death, I got to talk to the people that deal with the insurance. And that's not what we need here. We need people that want to deal with the situation, not the money, which is probably a different situation in Canada, but I'd imagine some of these themes, this lack of trust, you probably also see. Discontinuous care. So I end up with 2 or 3 different damn doctors and none of them know what's going on. So I'm going between 2 or 3 different people. It's good just to have one permanent doctor instead of having 2 or 3 different ones. So people acknowledge how important it is to have one doctor, but they're not getting connected to a doctor. Just being housed hasn't enabled them to establish with one doctor. and just poor access. Well, when I lived on the streets, my doctor, she would give me medication, and I go back and tell her, I can't take this. I live in a tent. So now that I'm here, I'm back on medication and whatever. But I didn't even know, which we have an on-site clinic here, I didn't even know that was there. And I've been here a year. And then a lot of what we just threw in this bucket called misperceptions, like people, which also kind of aligns with the lack of trust. This quote was pretty powerful. I then finally got tired of being used as a guinea pig, and I just left, because I go to the hospital to get better, not to be used as a guinea pig, as experimental. And a lot of these quotes are coming from a place where people have been treated terribly. People experiencing homelessness, as soon as you enter the emergency department, you're likely going to be faced with some traumatic event. And that lack of trust is going to be really hard for us to overcome as a healthcare system. And so what were the conclusions that we drew from these focus groups? While the first step in addressing the health and care needs of individuals experiencing chronic homelessness is housing, that's step number one, get people in a house. But there are still barriers to better health even after being housed. And that's a conversation that we haven't seen at the forefront as of yet. And that any intervention aimed at improving health for people with this lived experience of homelessness, it must consider not only their observable physical health needs, but also their past healthcare system experiences as well. We got to be approaching these patients with trauma-informed care, and we got to be listening to patients and hearing how they're perceiving their care, because patients are never going to trust the system unless we understand the place with which they're coming from. And so tip number 4 is listen for unmet needs. It's super important to hear the voice of our patients and to know where they're coming from and how they have perceived their care. Because unless we know those things, we're not going to develop any intervention. There's no change that we're going to create for them or for others without having them on our team and being a part of our team. And so this is also from Leadership and Organizing for Change. Who are our people? What change do they want? How can they get the power they need to achieve that change? So organizing equals power, people, power, and change. So I just wanted to highlight like one way that I have seen that quote play out. People, power, and change is traditional research. Oftentimes, like the university has an idea, they create the research study design, and they create this action plan, and then they impose it or drop it onto the community and say, hey, this is what you should be doing to achieve the outcomes. But I just want to propose, I don't know if many of you have been exposed to community-based participatory research, but it's a whole different model of conducting research. You go to the community, they create the idea or express a concern that is investigated. You work together with the university and with service organizations, create an action plan together, mainly driven by the community, and implement change. And it's important. The whole mentality is that in CBPR, community-based participatory research, you are engaging the community in every step of the research process. And so here at Community First Village, a huge concern of many of my neighbors is that drug use has been on the climb, especially since the COVID pandemic. From 2019 to 2020, drug use, self-reported drug use, which take it with a grain of salt, very unreliable data, but seeing it increase from 2019 to 2020 was concerning, same with alcohol use. But even since then, 2020 to now, we all know overdose deaths have surged during the pandemic. The CDC has released this data, and we're seeing it firsthand here at the Village. And so to help address this, we created this group called the Wellness Advisory Board here at the Village. And that's something that I have fully taken on myself, is formulating this board, getting my neighbors to the table to lift up their voice and hear their concerns. So we created this group along with a team of researchers at the University of Texas here. And we have also brought in these community organizations Integral Care, which is a mental health group, Communities for Recovery, which is a recovery coach service, and Mobile Loaves and Fishes, which runs the village here. We're bringing them all to the table, and the majority of people are neighbors, and our whole goal is to empower neighbors and community stakeholders to foster a culture of wellness at Community First Village. And we've chose that word wellness because we heard from neighbors that the word recovery automatically shuts people down, that people are more likely to embrace this term of wellness as opposed to recovery. But that's something that we just heard that. It's not going to be true everywhere. And so we've created surveys that, like, the idea came from the village, of course. And we created surveys that are going to look at substance use rates, recovery capital, which means like how supported someone feels to enter recovery, and then a brief survey on the culture of recovery here at the village. We're going to do that every 3 months and give that data to the advisory board. The advisory board will create an action plan or an idea for how to implement or act on that data. And we'll come back to us, the research group, to say, hey, we actually now want to focus in on this. How can we change the surveys to capture that? And then continue this iterative process, which looks a lot like a PDSA cycle in some ways. And so this is where some of the model for improvement has really been ingrained in me in some ways. And so this June is when we're going to start the surveys. So sorry that I don't have any data there. But the biggest tip here, and I'm sorry for being long-winded on these projects out here, is nothing for us without us, which actually this used to be written on IHI's office. Like as soon as you walked in their office, it says like nothing for us without us, and include patient voice. It's so important when to really be a change agent. It's not, a lot of times that word implies that it's us that are changing others, but really it's us, and us isn't just us change agents, it's us, the community, that's creating this change. But it's up to us, the change agent, to organize around that change. And I think I'll just leave you with one more tip, and we'll skip the 7th one so we have plenty of time for questions. But I just want to share with you, I'm sure you've seen all the music gear in my place and saw me playing with my pops earlier. I'll just play a short little blip here, just because there are, I think, like 7 of us neighbors. Hey, what's up, Pop? And I wanted to share that mainly to just appreciate and share with you guys that it's been through music that I have really bonded with my neighbors. And when you're playing music with others, like you're on the same playing field. If you're a musician, like you just automatically understand. Musicians are different, trust me, but you connect with that people. It doesn't matter your race, doesn't matter your socioeconomic status, and that being vulnerable in that way and inviting people into my space. So like all of this gear and stuff that you see, like this is gear for my neighbors, and creating a place where people feel safe to express themselves has really changed me. And that's how you get to know your community, is allowing yourself to be changed and inviting these people into your life in more than just the surface, at the surface level. It's really allowing them to teach you all these life lessons. And I'm just in awe of what my neighbors have been through, the struggles that they've overcome to get housed, and the struggles that they still face in their lives. It's just mind-blowing that they stay sane. And I am in awe by them every day of my life that I've been living here. And I'll carry that with me the rest of my life, seeing that inspiration and seeing that people with this lived experience, like they're very similar to me. They often love music and they love to hang out. And that's been being vulnerable and using my natural talents to connect with others has really helped me accomplish and connect more with my neighbors than I think I would have otherwise. And I just want to bring up this concept of public narrative, super important way to connect with others. This framework, just recognize it now, but this is such a powerful way to motivate people around your change, around your cause. And that's to tell your story in a compelling way and explain why this is so important now and why we need to be called to doing this. And so like, I was going to have us practice doing that, but just in the interest of time, I want to make sure that we have plenty of time for questions, should there be some. I'll try to maybe model that, and I honestly haven't given this much thought, so I apologize if it doesn't deliver. But for me, I think it's time for us. I have been so changed by people who use substances and by people that have experienced homelessness. It's because I've seen them as people and I've heard their stories and I know what they've overcome. And from that experience, my heart will never be the same. And I think it's time for us as a healthcare community to allow ourselves to be changed by our community. And in doing so, it's just going to make us stronger, more compelling organizers towards moving society towards a better future. And so I was honestly kind of making that up off the top of my head, but I tried to start with a story of self, talk about why we need to do this now and why we need to move towards this change. And so I will end there. Let's do a review. Tip number one, to be a change agent, is pick the right cause, identify your assets, use the model for improvement, listen for unmet needs, include patient voice, be vulnerable, and tell your story to others. And you will be well on the way to being an agent of change in your community. And so please, here, if you would like, I'll put my information in the chat box so that we can take it off the screen for questions. But I'm just so appreciative of you guys asking me to be a part of this. It's so much fun to prepare for. And I just am in awe with you guys for organizing such an impressive conference. Listening to Kadar speak, like that's a high profile speaker. That's a big deal. I wish that I could have made it to his talk. But I commend you guys for all your time organizing around that. And I really think that you're going to make a difference in your schools and in your training.
Thank you very much, Dr. Christian, for sharing your experience. That was very inspiring. I'm just going to wait for some questions to roll in the chat. But I guess in the meantime, I would ask, you mentioned how important it is to include patients. And I wonder if there are any challenges, as I'm sure there will be, to participating or to engaging in community-based participatory research, and whether you've experienced any of those and whether you have any of those off the top of your head.
Oh, it is dirty. It is messy, but man, it's fun. It's like, it is, you have to relinquish control. And that's a really difficult thing for a lot of us in healthcare. But once, like, I feel like I've been practicing this relinquishing control for 3 years now, having people knock on my door all hours of the day, or like, my day is always going to be changed by someone else. And I've accepted that, and I've had that training. And so I think that this process of organizing this advisory board, it hasn't been all that different from my other experiences. And once you let go of control, like thinking that this is what this board needs to look like, to thinking like, well, this is what the community wants. This is how they're organizing. They're organizing in this way. There has to be some element of acceptance, and things always will move slower than what you expect. And that's because relationships don't happen overnight. They take a long time to develop, and intentionally meeting with members of your board, or intentionally developing that trust over time. I mean, that's one reason why this has worked here. I've lived here for a while. Everyone knows me, and people trust me. They know that I'm not going to tattle on them for talking about their drug use to me. And so like, you got to develop the trust, and you got to have acceptance that, you know what, this board, once we launch it, like, it's out of my hands. It's going to look very different than what I expected. And people are going to over talk each other. A lot of my neighbors, they've never been like in a board type setting. And so like part of it is also training. And that's going to be a really vital part, is to like train the people on the board. Like, hey, this is how meetings work. This is your role on this board, but we want to hear you and we want you to be you. And like, it's a really hard dynamic, but it's really messy playing out, and it inevitably rolls out way slower than you expected.
Yeah, for sure. I guess, could you comment on like some practical ways that I guess researchers could kind of gain the trust of the community? Like how do you get the community to work with you and that sort of thing? Because I imagine, like you said, it takes a lot of time to do that, and you got to set that foundation before you really, I guess, engage them in the research.
So, I mean, it's a little tongue in cheek for me to say you should just live in that community that you want to serve. But like the reality is that all of us can't do that. But it certainly helps. Like that's how you really get to know people. But alternatively, there are a lot of people here that are interested in becoming missionals, and they're in that process of wanting to live out here. And the way we know that they're serious is by like the relationships that they have developed with people. And how you develop relationships, like what it looked like for me. I didn't share this whole story, but like I moved into a tiny home in Austin, and then my landlord didn't zone the property correctly, so I got kicked out. So I was like kind of homeless as an intern for a period of time. I lived with one of my buddies, and someone was like, "Hey, Nick, you should have you heard of this village of tiny homes?" They didn't even tell me that people experiencing homelessness lived here. And I was like, no, I haven't. And they're like, well, you should read this book. And I read this book by Alan Graham that like was really groundbreaking for me and hit me on so many levels. And so I was like, I'm going to come out to the village and I'm going to see what this is about. Well, the first person that I met when I was just walking around was the guy in that news video. My pops, JR is his name. And we just hit it off from the start. Like I said in the video, we started just playing music together. He told me after the fact, he just thought that I was going to be like most volunteers that come out, that like people say that they're going to do things or overpromise, but they don't deliver. And that's part of why this population is so jaded by people, is like people have promised them thing after thing and not delivered on it. Whereas like for me, all I focused in on was like just doing what I say I'm going to do. Even if I like can't come out to visit him on a weekly basis, it's more about when you say you're going to do something, you do it. And that's how you develop trust. That's something that we all have within our control to help develop trust with others. Now, trust is a two-way thing. Like it requires work on the other person's part too. So there's no like go-to on how to develop that trust. But if you want to work with a certain population, try to create a relationship with someone there and hold yourself accountable to, if you say you're going to meet someone for coffee, or, hey, I'm going to call you next week, put it on your iCalendar so that you know you're going to hold yourself accountable to doing it. And one thing that I have been fascinated by is like my neighbors remember everything. Like if I even just say, hey, oh yeah, I think I have a box of Cheez-Its at home or something, they'll like, and I'll say it just in passing, they'll come to my place the next day and be like, hey, where's that box of Cheez-Its? And I was like, oh, I was just saying that because you said you were hungry or something. But like the smallest things, like those are the assets that people experiencing homelessness have. They have each other, your relationships, your word. And so like that's a cultural thing that it took me a while to pick up on, but it also like plays in nicely to how you develop trust. It's like, just do what you say you're going to do.
Great. Thank you very much for that answer. And thank you very much for being here. Unfortunately, we're out of time. But I want to thank all of the people that attended the conference today, this session, and also thank you very much, Dr. Christian, for being here. I hope it was helpful for you, and it was definitely very helpful for us and a great learning opportunity.
No, thank you so much, guys. And Andrea, Sarah, and Rodrigo, if you want me to reply to your comments, just put your email address in. I'm happy to send an email. But thank you so much, everyone, for your time. Like I said, you're doing incredible stuff. Just organizing something like this, you're above the curve. So congrats to you all on a successful event.
Thank you very much. Thanks, everyone.